Good morning. Can you hear me? Is this on? Can you hear me okay? Great. Okay. Well, it is my distinct pleasure to introduce today's Grand Round speaker, Dr. Emily Pizzettes Key, who's going to be speaking to us on suicide risk and eating disorders. Dr. Pizzettes Key is someone who's been on our faculty for close to a year? 6 months. Half of a year. Feels like close to a year. She completed her doctoral work at UNC Chapel Hill and then came here. She's been here for a while because she was in our postdoctoral training program in eating disorders research for several years and has now come onto the faculty. She's been a very highly productive trainee and now faculty member. She's published widely in these areas. She's already gotten funding from several sources, including the Minnesota Obesity Center and CTSI. And she's received a number of awards. I won't go through those in detail, except to point out that in 2015 she was selected as just one of 2 University of Minnesota-wide most outstanding postdoctoral trainees. All departments, all schools, both campuses. Very impressive award. Her research work is, and her program that she's going to tell us about today is in the area of suicide, specifically as it pertains to eating disorders. I believe she will make the case that this is a particularly important thing in eating disorders. But I also would bear in mind the case that this kind of work is highly important because it tells us not only about suicide and eating disorders, but suicide as a phenomenon more broadly. Please join me in welcoming.
All right, can you all hear me? Okay, good. Well, thank you, Scott, for that introduction, and thank you for the department for inviting me to speak today. It's particularly good timing for this talk because it's actually National Eating Disorder Awareness Week, so I'm honored to get a chance to talk to you about the work I've done. Start off by acknowledging the funding sources and telling you that I don't have any disclosures to make. I'm not going to be discussing any off-label or investigational use. So I wanted to give you a little bit of a story about how I got to this point. So I was a psychology undergraduate and had a sense that I wanted to do some research and go into graduate school. So I volunteered to work in a lab. So I was going to spend my sophomore year summer in an eating disorder research lab. And on my first day, the PI I was working with said, please get all of your paperwork done in the morning because there's a meeting I want you to go to this afternoon. It's called an M&M meeting. I did not know what that was. I assumed that had nothing to do with the candy, but other than that, I really didn't know what I was going to be walking into. And what this meeting was that unfortunately, the week prior, one of the patients had died by suicide. This was one of the top eating disorder programs in the United States, in Southeast US, using evidence-based treatment, and it was led by one of the leading researchers in suicide. And yet still, unfortunately, this terrible consequence had happened where they lost this patient, which really led me to my work of trying to understand how can we more effectively prevent death by suicide in individuals with eating disorders. So this has been the question that's driven me for the past decade or so. And spoiler alert, I'm not really going to have the full answer for you at the end of this talk, but I think we've done important work to get us a little bit closer to answering this. So that's what I'll be going through today. Underneath that main question, there's really been 3 questions that have driven me and that we'll be going through today. So first, which individuals are at highest risk? Why are individuals with eating disorders at such high risk? And then how can we translate these basic research findings into clinical care? So before we begin, I just want to go through some terminology, make sure that we are all on the same page about what I'm talking about today. So I'm going to be talking about 4 different eating disorders. The first is anorexia nervosa. This is a disorder characterized by the hallmark feature of low body mass index, low BMI. There's a restricting subtype, so that's folks who achieve that low BMI purely by restricting their intake or overexercising without compensating calorically. And there's a binge purge subtype, so that's folks who also engage in binging behaviors or purging behaviors. This affects about 1% of the US population. Bulimia nervosa is folks who engage in binge eating behavior, which is eating an objectively large amount of food in a short period of time and having a feeling of loss of control associated with it. who also engage in purging behavior. So that might be self-induced vomiting, laxative misuse, things of that nature. And this affects about 5% or 3% of the population. I'll also be talking about binge eating disorder, which for those of you who are familiar with the DSM, just became an official diagnosis in the DSM-5. It was an area worth further study prior to that. This is folks who engage in that binge eating behavior and have distress about it, but don't engage in any compensatory behavior. This is one of the most prevalent eating disorders. It affects about 5% of the population lifetime. And then finally, I'll be talking a little bit about purging disorder, which is not a diagnosis yet in the DSM, but is an area worth further research. And this is folks who engage in purging behavior in the absence of any objective binge eating. So there's going to be a little bit less research for binge eating disorder or purging disorder, given that these were more recently recognized disorders. I also want to be really clear what I'm talking about when I talk about suicide. So I'll be talking a little bit about suicidal ideation, which is thoughts about self-inflicted lethal harm, a suicide attempt, which is self-inflicted lethal harm with at least some intent to die that does not result in a fatal outcome, and then a suicide, a death by suicide, which is self-inflicted harm with at least some intent to die, which does result in a fatal outcome. So I know I had this very formative experience when I was early on, but this is really an empirical question. Are people with eating disorders at increased risk of death to suicide? So I'm going to start by going through some of the work actually from Dr. Crow, which came from decades of work of clinic data that was collected here at University of Minnesota. And what Scott did was he was able to connect those clinic databases to the National Death Index, which is a computerized death record for the US, which has been maintained by the Center for Disease Control. And on death certificates, there's a cause of death. So he was able to link that and look for deaths due to suicide. So first we'll show the crude mortality. So you'll see here about 4.5% of the folks had died since coming into our clinic to be seen. And here, this was in DSM-4. So at this point, we had anorexia, bulimia, and then eating disorder not otherwise specified. So the binge eating disorder and purging disorder folks will be in that last category. But when he looked specifically at deaths by suicide, we did see an elevated standardized mortality ratio. And I want to make sure I'm clear about what I'm talking about when I talk about a standardized mortality ratio, because I'll be using that throughout my talk. A standardized mortality ratio is the risk of somebody dying compared to an age and gender matched peer. So somebody with an eating disorder was about 1.7 times as likely to die over that time period as an age and gender matched peer. You can see that was pretty stable for each of the diagnoses. And this has been a finding that has been replicated now many times. So in fact, eating disorders actually have the highest rate of, have the highest mortality rate of any psychological disorder. And the standardized mortality ratio, this is from a more recent meta-analysis than Scott's study, found actually even more alarming numbers. So someone with anorexia is about 6 times as likely to die than someone with an age and gender matched peer, and someone with bulimia nervosa is about 2 times as likely to die. Again, I don't have binge eating disorder or purging disorder data, just since these are slightly newer diagnoses. When we looked at death by suicide specifically, before it was just any cause death, the suicide standardized mortality ratios are even more alarming. So in the entire sample, they were about 7.7 times as likely to die by suicide as an age and gender matched peer. And again, this has been replicated. So in a recent meta-analysis, they found a standardized mortality ratio for death by suicide for anorexia of 31. So an individual with anorexia nervosa is 31 times as likely to die by suicide as an age and gender matched peer, and an individual with bulimia nervosa is 7.5 times as likely to die by suicide as an age and gender matched peer. I don't have any specific standardized mortality ratios for death by suicide for binge eating disorder or purging disorder, but Scott's study would indicate that they also have an increased risk of death by suicide. For most of the rest of the talk, I'm actually going to be talking about suicide attempts, and there's a reason for that. The first is that investigating death by suicide is it's really hard to do. You have to have large sample sizes, and you have to follow them for a long time. So fortunately, eating disorders are a low prevalence disorder, and even more fortunately, death by suicide is still lower prevalence within this population. So it just gets very logistically challenging to only study death by suicide. But there is a really strong rationale for looking at suicide attempts, and that is that a previous suicide attempt is the best predictor of a later death by suicide. So if we study the folks who have made a suicide attempt, that does give us some insight into folks who are more likely to have later die by suicide. So that gets me to this first question. So which individuals are at highest risk? So are there certain eating disorder diagnoses that are associated with greater risk? This is the work that made up my doctoral dissertation that was done at University of North Carolina. And I had access to the Swedish twin registry, specifically the stage cohorts. These are twins in suicide or twins in Sweden, and twins in Sweden are referred to lovingly as two cherries on a stem, which I just think is such a great image. So I always put that up there. And these were twins who were sampled in 2005. They were anywhere from age 20 to 47 at time of sampling, and we had just shy of 13,000 twins who were part of this cohort. And what I was able to do was to link the data from the Swedish twin registry to two different registries in Sweden. So they have the hospital discharge registry. So any hospitalization in Sweden is part of this registry. So this is my plug for how wonderful it is to do research in countries that have nationalized healthcare that make these registries available for research. And any hospitalization has an ICD code that goes along with it. So you're able to search these hospitalizations for ICD codes related to suicide attempts. And then I also had access to data from the cause of death registry, and we had data available through 2005. So again, when anybody dies, their data goes into this registry, and you're able to search by ICD codes. Now, they were sampled in 2005, so they had to be alive in 2005. So we only had a very small window for deaths by suicide. So we decided a priori we were going to combine that and look at suicide attempts and death by suicide together. So these were our findings. So to orient you to this table, we have no eating disorder at the top. So about 1.5% had a suicide attempt or death by suicide. And then the second line is the anorexia nervosa restricting subtype. The third line is anorexia nervosa binge purge subtype. And then in this study, I actually looked at a different category, which was anorexia nervosa, bulimia nervosa combined. So those are folks who met criteria for both diagnoses at some point in their life. And then bulimia nervosa and purging disorder and binge eating disorder. The overall model was significant. There were differences, and post hoc analyses indicated that all of the eating disorder diagnoses had higher prevalence of lifetime suicide attempts or death by suicide than no eating disorder. And I will note that the no eating disorder group consisted of folks with other psychopathology, but no eating disorder. Another note about these numbers, they range from about 1.6 up to about 13.5. These were only suicide attempts that resulted in a hospitalization. So this is a pretty high bar. Also, some of these folks were as young as 24 at the time the study took place. So again, I think these are going to be pretty conservative numbers for what we see over the lifetime. This is to show you in graphic form, since sometimes that's easier for folks to digest. And again, you'll see all of the eating disorder diagnoses had higher prevalence of suicide attempts compared to the no eating disorder group. Then we also looked within eating disorder diagnoses to see if there were any differences there. And what we found there is that the anorexia nervosa, bulimia nervosa group, so those folks who had met criteria over the course of their lifetime for both diagnoses, folks with bulimia nervosa and folks with purging disorder had higher prevalence than the anorexia nervosa restricting subtype group. So that gives us some indication that folks who engage in purging were more likely to have had a suicide attempt. A few additional results. There was no difference in the methods of suicide attempt between those with an eating disorder and those without. And I always bring this up and talk about this because for a long time there was a hypothesis that the reason for the increased mortality in individuals with eating disorders are that they were at risk or that they were medically compromised. So these were folks who maybe weren't making quite as lethal of a suicide attempt, but because they were at low weight, because they had their heart was weaker, that they were just more likely to die. And what we find is that folks with an eating disorder are just as likely to make a violent suicide attempt, so hanging themselves, things of that nature. Additionally, we looked to see if there was any comorbid psychopathology that was leading to this increased risk. And what we found was that there was a higher prevalence of suicide attempts in folks with at least one comorbid diagnosis, but no specific comorbid diagnosis came to the top as driving this association. So the next question that I wanted to ask was whether there's any personality traits that are associated with greater risk. So the goal of this study was to examine whether there's specific personality features associated with a lifetime history of a suicide attempt. And here I looked at 2 independent samples of women with bulimia nervosa. One was a multi-site sample, and one was a sample actually from colleagues in Fargo, North Dakota. But both of these samples had given the dimensional assessment of personality pathology. This is a standardized personality inventory that has 18 subscales that load onto 4 main dimensions of personality. So emotion dysregulation, dissocial behavior, social avoidance, and compulsivity. So first from sample 1, I'm only going to show you results from the emotion dysregulation subscale, or broad factor, because that was the only thing that came out as significant. So in the first sample, we saw elevated anxiousness, cognitive dysregulation, and identity problems in folks with a lifetime suicide attempt compared to folks without. And then in the second sample, again, I'm only showing you results from emotion dysregulation because that was the only scale that came out as significant. We found higher identity problems and insecure attachments in the folks with a lifetime suicide attempt compared to those without. So in 2 different samples, we replicated our finding that identity problems were associated with a lifetime suicide attempt. And although the other specific traits didn't replicate across the sample, we are getting a sense that emotion dysregulation was higher in folks with a suicide attempt. Now that was samples of individuals with bulimia. That's because that's what I had access to. But as we move to thinking about things more transdiagnostically, I wanted to know, are there dimensions of emotion dysregulation associated with suicide attempts across the eating disorder spectrum? So is this specific to bulimia nervosa, or is it in eating disorders more broadly? So what I did here was ask whether there are specific dimensions of emotion dysregulation associated with a lifetime suicide attempt in a transdiagnostic eating disorder sample. And I want to acknowledge our collaborators from the Emily program who helped us collect these data. So here, what we did was administer the DIRS, which is the Dimensionless Emotion Regulation Scale, which results in a total score, and you'll see that there was no significance in broadly defined emotion dysregulation in those with a suicide attempt compared to those without. But there was a significant, a higher level of the impulse subscale and the clarity subscale with small effect sizes. So some indication that there are specific facets of emotion dysregulation associated with a suicide attempt. So again, there was no difference between those with and without a suicide attempt on broadly defined emotion dysregulation, but we got some indication that individuals with an eating disorder who have a lifetime suicide attempt showed greater difficulty controlling their behaviors when they're upset, and they have worse emotional differentiation. So this gives us some indication of places we might be able to intervene. So the next question is, okay, now that we've identified that these folks are at higher risk, we're starting to have a better sense of who may be at higher risk. Why? Why do we see this elevated risk of suicide in individuals with eating disorders? So one question is there a shared genetic liability? Is there something genetically connecting these two, eating disorders and suicide? So we know that both eating disorders and suicide aggregate together in families. Do they aggregate in the same families? So what we did here was look at prevalence of a family member suicide attempt for a proband with an eating disorder. So this was, again, our clinic data. So you can see any family member we had back for the eating disorder not otherwise specified, about 7% had a family member who had attempted suicide, up to, in the purging disorder, about 17% had a family member who had attempted suicide. And we didn't have a control group because this was our clinic data, but just to give you some orientation to compare these numbers to, if you look at an individual with major depressive disorder who has died by suicide, about 10% will have an additional family member who has attempted suicide. And if you look at an individual with major depressive disorder who has not attempted suicide, about 6% will have a family member who has attempted suicide. So we're seeing numbers comparable to those who have died by suicide. The overall model was significant. Interestingly, when we controlled for the participant's age and the participant's gender, the difference was between the bulimia nervosa group and the eating disorder not otherwise specified group. It looks like there's also elevated in the purging disorder group, but that was such a small group that did not hold statistically. And also there was a difference specifically in mother suicide attempt. So again, we see a same pattern of findings. Once we control for participant age and gender, we see an elevated rate of mother suicide attempt in the bulimia nervosa group compared to the eating disorder not otherwise specified group. Now, you're a savvy audience, you're probably thinking this does not actually get us at whether there's a shared genetic liability because these are family members who grow up in the same environments. But this does indicate that they do go together within families. There have been a couple of twin studies that have tried to parse that out. So is this a shared genetic? There was a twin study that found a shared genetic pathway for suicidality, which they defined as suicidal ideation, and any eating disorder group. So they combined. Even with these sample sizes in the 13,000s, these twin studies just need a lot of power. So they did the best they could. And then a separate twin study found a shared genetic factor for anorexia nervosa and actual suicide attempts. And that was my colleagues at University of North Carolina using the Swedish twin registry. And further, they found that individuals with full siblings with anorexia or bulimia have increased risk of suicide attempts. So we're getting an idea here that there may be a genetic underpinning that's shared. Now, as a psychologist, I really want to know what are the psychological vulnerabilities, because that's where I'm able to intervene. I'm not able to intervene on the genetics at this point. That will be somebody else's specialty. And the model that has really interested me and where most of my work has focused is on the interpersonal theory of suicide. And this was a model that was first posited by our colleague Thomas Joyner at Florida State University a little over a decade ago. And what Dr. Joyner did is he took all of the existing literature for risk factors for eating disorders, or for suicide, and tried to see if he could come up with a comprehensive model. And I know there's a lot of arrows and diagrams here. I'm going to walk you through this model. But what Dr. Joyner indicates is that in order for somebody to have the desire for suicide, or what we think of as suicidal ideation, they must have both thwarted belongingness and perceived burdensomeness. Thwarted belongingness is the idea that I am alone. Perceived burdensomeness is the idea I am a burden on other people. So when those two things go together, that's when somebody's at increased risk for suicidal ideation. What I find most compelling about this model, though, is that he has a hypothesis for what brings people from suicidal ideation to suicide attempts, because we know most people with a suicidal ideation will never make an attempt. And what he says here is that folks have to acquire the capability. So evolutionarily, our goal is to stay alive and procreate, and you really have to be able to overcome that to take your own life. And what he says you need there is to have a decreased fear of death and an increased pain tolerance. So again, I'll talk a little bit more about each of these constructs. So thwarted belongingness, and this is a quote from Leila Alcorn's suicide note. This is the transgender teen who committed suicide, unfortunately, a couple of years ago. And in her note, she said, "No friends, no support, no love, just my parents' disappointment and the cruelty of loneliness." So again, this is that idea that folks who think I am alone are at increased risk. This comes from literature that indicates a recent loss puts somebody at increased risk. So death of a family member, a recent divorce, people who are actually in single jail cells are at higher risk, people who don't have a lot of social support. So again, he was taking a lot of the findings and trying to put it together, came up with this concept of thwarted belongingness. For perceived burdensomeness, in Virginia Woolf's suicide note, she said, "I know that I'm spoiling your life. I can't go on spoiling your life any longer." So this idea that I am actually a burden on other people. And this comes from the research indicating that people who are unemployed are at higher risk of suicide. People who have a chronic illness and are depending on their family are at higher risk. People who feel like they are a burden on other people. And then finally, for that acquired capability, Kevin Carter is a photojournalist who took the Pulitzer Prize-winning image from the Sudan of the starving child. And in his suicide note, he said, "The pain of life overrides the joy to the point that joy does not exist. I'm haunted by the vivid memories of killings and corpses and anger and pain. of starving or wounded children, of trigger-happy madmen, often police, of killer executioners. So this is the idea that the more you experience painful events throughout your life, the more you have a decreased fear of death. So this comes from literature showing that people who've experienced war are at higher risk, people who've experienced interpersonal violence, who've engaged in more painful events throughout the course of their life. So you get that decreased fear of death, which puts people at higher risk. So this is the model that we'll be talking about how it applies to eating disorders. And it's only about a decade old, but already has quite a bit of empirical support in community samples, undergraduates, military samples, prison inmates, older adults, and various forms of psychopathology. There was a couple of studies looking at it within disordered eating, but I was really interested, does this apply to eating disorders? There's a few reasons why I was so drawn to this theory. The first is that if we think about that thwarted belongingness, that idea that I am alone, we know that individuals with eating disorders have smaller social networks. So if you ask an individual with an eating disorder who they can turn to, they name fewer people than if you ask a healthy control. They also report being dissatisfied with the support that they have. So this gives us some indication they really may be at risk for this feeling of being alone in the world. In terms of perceived burdensomeness, individuals with eating disorders are often dependent, both emotionally and financially, on their family. So these are folks who don't achieve as much academically or employment-wise. They often end up living at home. These treatments are extremely expensive, and so they do often end up being dependent on their family. And their caregivers endorse an extremely high level of burdensomeness. Family members of individuals with eating disorders report higher levels of burdensomeness than family members of individuals with schizophrenia. These are very, very burdensome disorders for family members to deal with. And so it may be that they perceive they're a burden. It may also be that they're getting messages from their loved ones that you are a burden on me, this is draining me. So those two things together really make me think that they may be at higher risk. And then in terms of the acquired capability, there is actually research going back within this department, back decades, showing an increased pain tolerance in individuals with eating disorders. And then if you think about some of the factors we've been talking about, purging is a physically uncomfortable thing to do, but these patients are able to do it. Starvation, being at a low weight, is also physically uncomfortable, but yet these patients are able to do it. And many of them engage in excessive exercise, which again, they're exercising to the point of exhaustion, falling down, and there has been some data to link excessive exercise with suicide risk. So this led me to the question, okay, it's an interesting model. Does it work within eating disorders? So here what we found, we looked at thwarted belongingness, this construct, and perceived burdensomeness. And within a transdiagnostic eating disorder sample, we did find each of those constructs were associated with suicidal ideation. So that first part of the model. Then we looked at the second part of the model. So of folks who had suicidal ideation, were folks who had decreased fear of death or increased pain tolerance, were they more likely to have had a suicide attempt? We did find that the painful and provocative event scale, which I did not name that scale, I hate the name of it, but what it is a scale of painful events that individuals might have experienced over the course of their lifetime. So this is things like getting a tattoo, substance use, physical abuse. That has actually been associated with increased pain tolerance. And what we found is that the more painful and provocative events somebody had engaged in over the course of their life, the more likely they were to have made a suicide attempt. Interestingly, we did not find that decreased fear of death was associated with a suicide attempt. So in terms of whether this model fits for eating disorders, we have support now that the first half of the model works, so both thwarted belongingness and perceived burdensomeness are associated with suicidal ideation. And then some elements of the second half, so that increased pain tolerance or a proxy measure of the increased pain tolerance was associated with suicide attempts. We're not totally sure why we didn't find the decreased fear of death. I have some hypotheses, but I'd also love to hear other people's hypotheses about that at the end. And then in terms of putting this together with the previous findings, so we did find that people who had engaged in purging were more likely to have a suicide attempt, and this seems to fit within that acquired capability model. So people who engage in this painful event over and over and feel some emotional relief from it, I hypothesize that fits in with acquired capability. And then in terms of emotion dysregulation, that was the other consistent finding we've had. We'll talk about where I think that fits in. So it's all great and good to study this larger model, but really the question that drives me is, what leads someone to consider suicide in the moment? So not over the course of their lifetime, what are the risk factors, but what really drives that decision in the moment? So in terms of Thomas's model, he has arrows directly from thwarted belongingness and perceived burdensomeness to suicidal ideation. I'm a cognitive behavioral therapist at heart. I have to think of things in terms of cognitions, emotions, and behaviors, and I think that there's more going on here. So if you think of thwarted belongingness as the cognition, the thought, I am alone, and perceived burdensomeness is the thought, I am a burden on other people. How are you going to feel if you have those thoughts? Probably pretty badly. Those are probably going to lead to some negative affect in the moment. Depression, guilt, shame. Now, many of us may have the thought, I'm alone, I'm a burden on my family or friends, and that may stir up some negative emotions. But that's not going to always lead folks to think about suicide. But when you have emotion dysregulation, that's probably what leads to the spiraling. So if you're not able to regulate that negative affect in the moment, that's what's going to send somebody down the path to be more likely to think about suicide attempt. Now again, as a CBT cognitive behavioral therapist, I always think about what's reinforcing. So if you have the thought, I am alone, I am a burden, you feel guilt, shame, sadness, you then have the thought, well, I could take my own life. That may actually reduce your negative affect in the moment. You may say, okay, I know what I can do about that. That makes me feel better. When your negative affect goes down in the moment, that's probably reinforcing that thought. And that makes you more likely to turn to that thought in the future because you had that reinforcement. Now, interestingly, I also think about the feedback loop to thwarted belongingness and perceived burdensomeness. So as I mentioned at the beginning, folks who have had one suicide attempt are more likely to later die by suicide. If you have a suicide attempt, you end up in the hospital, you end up, there's all sorts of consequences that can come from that. That may lead you to feel more isolated. People don't get you, they're blaming you, they're shaming you. You may be a burden on your family because you ended up in the hospital, you lost your job, and that might start the cycle over again. So I really think of this as all sorts of feedback loops and trying to understand what leads to that in the moment. I'm also really interested in why these individuals are at such high risk for having those thoughts in the first place. So why are they so likely to feel alone and to feel burdensome? So that's another path, is what gets them down that path to begin with. So to summarize the research that I presented so far, we did find that individuals with eating disorders, particularly those with purging behavior, are at increased risk of suicide attempts. Emotion dysregulation specifically is associated with increased risk. There's some growing evidence that there may be a shared genetic underpinning between eating disorders and suicide. And the interpersonal theory of suicide does appear to be a useful lens through which to understand the increased risk in suicide in individuals with eating disorders. There's a few gaps in this literature. This is a pretty new and growing literature, so I wanted to talk about that. The first is the temporality of observed associations. So we are often predicting a past suicide attempt, which is highly problematic statistically as well as conceptually. But for some logistic, methodological reasons, that's what most of the research has come from. So I think we do need more longitudinal studies. And I think we need more studies of what happens in the moment. So not just following folks for 5, 10 years, but really saying moment to moment, how do all of these pieces of the puzzle come together? And so that is driving some of our work using ecological momentary assessment to try to understand those associations. In terms of models of suicide risk, I think we really need to figure out how to integrate the biological and the psychological. So not think of them as separately, but how do we come to a more comprehensive model where we fit these pieces of the puzzle together? Along the same lines, I think we really need to integrate both traits and momentary risk factors. So how do all of these things come together? I mentioned that I'm particularly interested in why individuals with eating disorders are at such risk for thwarted belongingness and perceived burdensomeness. And this is growing literature that really comes out of London right now that's showing individuals with eating disorders have social cognitive deficits. So it may be that they are not picking up on social cues to get the support that they need, or they're not able to reciprocate that and maintain those relationships. And there's some really fascinating work coming out of colleagues at Florida State University and Vanderbilt looking at machine learning. So how can we keep using all of these new studies and come up with a more effective model of suicide risk? And then the final thing is, we're not doing this exercise just for an academic exercise. We really need to translate this into targeted treatment and prevention. And that gets to the final question. How do we translate these findings into our clinical work? There are a few treatment implications. So one is targeting emotion regulation in these patients. So working on increasing ability to control behaviors when they're upset, improving emotional differentiation skills, introducing problem-solving skills, and developing a variety of coping skills. And within eating disorders, traditionally we have done more cognitive behavioral therapy, but I think this really indicates that we need to be doing more emotion-focused work. So there's some work adapting Marshall Linehan's dialectical behavioral therapy to folks with eating disorders. And then coming out of our own research lab led by Dr. Carol Peterson, integrative cognitive affective therapy, which has been shown to be evidence-based for bulimia nervosa, and we're currently testing it in binge eating disorder. So again, with these folks, we may want to do some more work specifically on emotions. In terms of targeted interpersonal interventions, there are some strategies that you can do to increase belongingness. So you can work on connecting people to their social support networks, integrating their social support networks into treatment in an active way, and working specifically on improving social skills. Additionally, we can help folks reduce their perceptions of burdensomeness. So some of that may be more basic cognitive behavioral therapy where we're challenging those cognitions, challenging the cognition, I am alone, I am a burden. You can also work with your patients on activities to increase their self-efficacy. That may be something like volunteering, getting them integrated into their community, doing meaningful things so they don't feel like they're so much of a burden. This indicates that interpersonal psychotherapy may be particularly effective for some of these folks, and indeed that is an evidence-based treatment for eating disorders. Family-based therapy, which is the treatment of choice for adolescents with anorexia nervosa, so bring that social support network into treatments. And then some of the work that I was involved in at University of North Carolina, which is bringing in the partner into adult treatment. So how can we leverage that social support? So as I mentioned, I don't quite have the answer to this question, but hopefully I've gotten us a little bit closer, and I think some of the work that my colleagues and I are doing is getting us a step of the way closer to understanding how we can more effectively prevent death by suicide in individuals with eating disorders. So before we wrap up, I have to acknowledge my wonderful colleagues here at the University of Minnesota. Excuse me. I've only been here 4 years and I get that mixed up. My colleagues at the University of North Carolina, my colleagues at the Karolinska, colleagues in North Dakota at the Neuropsychiatric Research Institute, and then all of our T32 faculty and fellows. Of course, I need to acknowledge the grant fundings, but I really want to specifically thank the research participants who take their time, come into the lab, fill out these questionnaires, fill out the information on their cell phone, and really donate their time to research. So I want to make sure that we acknowledge them. Before I thank you and open it up to questions. Yeah.
Really nice talk.
Thank you.
The concept that came to my mind as I was listening to your presentation is this notion of the embodied self.
Mm-hmm.
The construct that came to my mind is the notion of the embodied self, which is the idea that our representation of ourself, both at an unconscious and at a conscious level, is constructed not just of emotions, thoughts, feelings, motivations, but also literally of the somatosensory data, kinesthetic data, proprioceptive data that is coming in at any moment in time and over time to create this sense of who we are. And that seems to play an important role in cognition and the ability to interact with others. It's a sort of a small growing area in both health and in psychopathology. And I found myself thinking, clearly people with eating disorders, that embodied self is extremely distorted and dysfunctional. I'm sure there's a bit of a chicken and an egg question to it, but it's definitely, the needle seems to have moved in the direction of really some disconnectivity, really, between all this important embodied information that's coming in and then the psychological responses to it. So I was wondering if that paradigm has been brought into it all in terms of the increased risk for suicide?
It's a great question. I have not seen any studies looking at that specifically within eating disorders. I think the prior model, though, has been that eating disorders are kind of a slow form of suicide within, hurting yourself physically. So I think we had kind of moved away from that for a little bit, but I think you're absolutely right that the sense of self is part of it. But I haven't seen any studies looking at that. Not that. Mm-hmm. Some work in the theory of mind, but not within embodied self specifically. It's a great question.
Thank you. Thank you. A couple questions. The near suicide attempts and suicide gestures, and also the age group of your constituents. Could you comment on that as to what you called what? And then secondly, the role of substance use disorders in eating disorders, and what role that might play in the story of people coming to suicide and attempting and even completing.
It's a great question. So the first question was in terms of this concept of what a suicide attempt is. So for the first set of data that I showed from the Swedish Twin Registry and Scott's data from the CDC, that was based on the physician's assessment. So they coded it as a suicide attempt. Within the Swedish Twin Registry, we also had codes that looked at probable suicide attempts. So when it wasn't completely clear, so an example of that may be a car accident where the physician hypothesized that there was some suicidal intent there. We did look at that as well, but the data that I showed today was specifically the physician coding it as a suicide attempt. The subsequent studies, we left that up to the participants. So we asked, have you ever made a suicide attempt where you have self-inflicted harm with at least some intent to die? So there's that, at least some intent. So that was not we did not code that, we left that up to the participant. We do typically also ask about non-suicidal self-injury and ask those together and differentiate them. So it's up to the participant really how they code their episode of self-harm. In terms of the age range, as I mentioned, the data from the Swedish Twin Registry, some of those folks were pretty young. So we do think that that's part of why we had lower prevalence, because as we know, prevalence of suicide attempts goes up with age. So those were probably more conservative numbers. The second question was about the role of substance use, and it's a great question. We do see, some studies have found that individuals with a comorbid substance use disorder are at higher risk. In my dissertation, we did not find that, but some studies have. And none of the meta-analyses have pulled that, within eating disorders, have pulled that together to show that substance use is a robust risk factor, but it has been indicated. I think conceptually it certainly is part of the model. So folks who engage in substance use are more likely to be impulsive, have emotion dysregulation problems, and if you think about that acquired capability element, if you are engaging in substance use, that can be painful depending on the type of substance use that you're doing. It decreases your pain tolerance. So I do think it fits in, but it hasn't been a robust finding at this point. It's a great question.
Have you looked at the factors in the social isolation? For instance, is part of it willful on the part of the person with the eating disorder because they want to cover up, not reveal, hide, not be exposed regarding their eating disorder? And also, is it partly a group reaction to people with eating disorder, that they sense that there's something a little off about this person and they just don't feel comfortable around them, so they don't include them the way they would another person?
Absolutely. It's a great question of what drives that social isolation. So is it that the individual with the eating disorder is kind of hiding out, or is it that they're being rebuffed from their social network? I have not looked at that, so I don't have empirical data to support my answer, but my answer is that it's most likely both. So that there is an element of these disorders that is very secretive, that you're often hiding these behaviors, you're withdrawing from your social network. But I think that there is some evidence to show these folks have difficulty engaging in social interactions, and that probably does make it harder for them to develop and maintain social connections. So they have trouble producing the appropriate social cues. So if you videotape them while they're having conversations, they're more likely to have a stony facial expression. They're not as likely to reciprocally smile. So if you're going to talk to somebody who's going to stone face you every time, you're probably less likely to want to talk to them again. And so I think that it absolutely is going to go both ways. But I have not dug into that as it relates specifically to suicide, but that's actually the next direction I want to see my research go. So it's a great question.
Emily, I have a question. Thinking about your comment about momentary risk factors for suicidal behavior, and it makes me think, we usually think about long-running risk factors, either trait risk factors like I'm impulsive, or maybe longer-running but state factors like my depression is pretty severe at the moment. If there are momentary risk factors also, are they worsening of those things, or are they different, do you think? Are they different factors?
That's an empirical question that we don't have the data to answer at this point. My guess is that they are exacerbations of those trait factors. So thinking about things like agitation has been associated with suicide risk. So is there sort of that momentary flip of the switch when somebody is more emotionally dysregulated? So rather than trait, I have trouble with my emotions, but in this moment, the emotion is so intolerable. So my guess is that it is momentary factors of these more longer term. I guess the question becomes, what would you put into a study to try to identify novel momentary risk factors if you aren't basing it on what research has shown us longitudinally? So I think you'd have to get pretty creative there.
I was wondering if you could draw a comparison between people who are obsessive and ruminate and the kinds of ideations that you're seeing in this population. If somebody is spending a lot of time thinking about how much they're eating, do they not spend a lot of time thinking about other things? And if they happen to stumble upon thinking about ending their life, do they continuously ruminate about that, for which then there is some impulsivity or some event that then draws them over the line?
Mm-hmm. It's a great question. So the question was about rumination versus impulsivity. And what the data shows is that folks who are more likely to make a suicide attempt are impulsive, but their suicide attempt itself is not made impulsively. So often they have actually planned it in advance, so they're less likely to make an impulsive suicide attempt. I do think that some of that rumination and thinking about things as a way to regulate emotions, that if I constantly come back to this idea that I have an escape, I have a way out, that can make somebody feel more empowered in the moment. It can give them an escape to this otherwise really aversive state that they're in, and some control in an otherwise uncontrollable world. So I do think that there is something really reinforcing about that ruminative state. Yeah, Calvin.
Hi, Emily. It was great to hear your perspective from the psychological perspective about your model. Have you thought about how one connects it with kind of Ardachian themes and circuits, and how do we draw these connections? Because we suspect there must be something. I was wondering how you've been thinking about that.
It's a great question that I've been spending a lot of time thinking about, and would love your thoughts because I've been struggling a little bit. And I will note that Thomas Joyner has not received any funding from the National Institute of Mental Health, so he does not think of these things in that terminology. The direction that I'm going is really thinking about the social cognitive deficits and the neurocircuitry around that. Going back to the shared genetic underlying, there is some data that there's some serotonin disturbance and things of that nature, but that has been what I've been struggling with. So, Scott, Kelvin wants to. Okay. So if you have thoughts, I would love to chat.
I always have thoughts.
Did you?
But I think but you've already mentioned some other aspects besides the social cognition part, but also there's a whole dimension on the impulsivity piece that that also ties into this. And then, of course, we often think about suicide associated with depression, and there's circuitry dealing with depression that has been studied for quite some time. So I think there could be some ways to kind of triangulate that, because I think it's not just one construct. I think it's going to be a combination of these that's going to be very important as we move forward.
I agree, and I think this is an issue. I mean, NIMH has come out saying suicide prevention is one of their top priorities, and when I talked to the program officer about how we do that in an RDoC way, he did not have a great answer for me. So I think this is something that NIMH is struggling with as well. So I think we do need to think about this in a dimensional and novel way, because what we are doing so far has not been dimensional. Yeah.
Ton of expertise in terms of assessing various dimensions of elemental social cognitive functions, using digital methods, and then, of course, of applying cognitive training techniques to move the needle on those. So, I mean, that's something we should think about collaborating on pretty quickly. But also, Kelvin's question just raises this is kind of an FYI, for your group. We've been meeting with an interdisciplinary team across neuroscience and psychiatry, really thinking through what might be a behavioral task panel. It's Ardocian, but it's much more driven by computational psychiatry approaches to understanding the information processing nodes or failures, similar to, David Reddish's Grand Rounds. And thinking about both in decision-making processes, evaluative processes, which would likely include some social cognition processes, habit learning, and I know I'm missing one, but I'm a little tired today. Perceptual processing, right. Which you wonder about. I don't know if anyone's ever looked at perceptual processing in eating disorders, but again, given the distortions in embodiment, you might think there might be some distortions there as well. Anyway, all that to say that we're trying to think about what might be a broad computational panel, which allows one to situate individuals across these, in a multidimensional space in terms of these various failures or combinations of failures that an individual might be having, and certain combinations may be more characteristic of eating disorders or impulse discontrol disorders, for example. But we should keep in dialogue about that approach as well.
Absolutely, that'd be great.
Are there more questions? Yes.
Could you talk a little bit more about how you would monitor folks in your ecological moment assessment and the challenges that would go along with that? And if you have any preliminary or anecdotal findings, that would be great too.
It's a great question, and as folks know, in this department particularly, we've been thinking a lot about this. We have not started data collection for that study. We put a pause on it when some things were happening in the department, but I think it's an empirical question of what is the best way to approach it. There are data that suggest actually the more often you ask somebody about suicidal ideation, the more likely they are to not endorse it. So that's another thing that we've been thinking about is if we ask them 6 times a day, are they going to just stop endorsing it? If we put up a red flag every time they endorse yes, are they going to be less likely to endorse it? The strategy that we have taken in most of our studies right now is to be very clear up front in the consent form that nobody is monitoring this in real time. If you feel like you are in danger, please go to the emergency department, please call the hotlines and providing that information for them. That seems to have worked fairly well so far in the studies that we've done. But it's a really fine line. As a clinician, my heart is that I want to intervene when somebody is telling me that they are at risk. As a researcher, I don't want to be influencing the data that I get. So I have really, really struggled with that. I know Scott and I have talked a lot about that, and some of our colleagues who are doing ecological momentary assessment work. So there are a handful of groups who are doing EMA with suicide, and they seem to be handling it differently. I think that comes a little bit from different ideological approaches to the research, as well as different IRB comfort level approaches to the research. So there is not a gold standard accepted way in the suicide EMA research at this point of how to deal with it. I think you're really just trying to find that appropriate balance between keeping our participants safe and not affecting the data. Great.
All right.
Well, I think there's some cheese and coffee out front. Or cheese. Oh, that's all gone. Sorry, you guys got that beforehand.
Oh, there may be. One.
Okay.
Thank you very much.
You have been